Okay, great. So here we are, 3rd of December. It's a week, is it, after Omicron was announced to the world, this new variant of concern that has a large number of changes, a large number of mutations happening in parts of the genome that look worryingly important in terms of what it might do in terms of changing the virus. We're still learning what this means for the world, for us, for how we deal with this. But I think it's a point in time when, in any case here in Ireland, things weren't going well. I mean, we didn't need Omicron to say we had a crisis. We were like rolling towards crisis anyway in the hospitals under huge strain, and now this on top of everything, I think, has just refocused everybody's attention on the fact that this is a long-term problem and we need different solutions. This living with a thing isn't exactly going well. So Paul Dempsey, I think you might have some snapshots of the data, and so much as we can see it, right? So that you can talk about where we are and maybe also the problems there are with even knowing what the data can tell us at the moment.
Sure.
Great. Cool. Can you make that? Yeah, perfect.
Yeah, so at the moment, things look like they're going okay with Delta. And now I'll go into a little bit later, just a few minutes, how that's may not be so true, and because we're not testing enough. But overall, it looks like things might have stabilized to a stable level. Such things don't really exist. There's always a mechanism behind them.
So here you've got the log scale, just to point out. So,
sorry. The only scale that's any use. So when we look at these type of graphs, the only scale that's any use is a log scale. So instead of going 1, 2, 3, 4, 5, you go 1, 2, 4, 8. So you go in multiples. And the reason why that for infectious diseases and lots of other problems like this is because we don't really just go from 1 to 1. It's one person gives us a 2, those 2 then go on to 4. So that's why the scale is always like this. So
exponential growth looks like a straight line on this.
Exactly. So
and on an ordinary graph, exponential growth looks like it's going along the bottom until it suddenly reaches the top all in one day, kind of thing.
Yeah, and then the next day it will look something completely different again as well. So it's not really a good way of looking at this.
And everything that goes before is squashed down the bottom of the graph.
Yeah, every single day. I mean, that's in the most extreme case, every day could be easily wiped out. But in a case where you might have doubling in a day, which is close to what they saw in South Africa at the moment, that's the kind of thing you can see.
This is the best way to look at this. So when we see a straight line heading up, that's
that's when
it's how fast your exponential growth is. How high this line is pointing on the log graph is how fast your exponential growth is.
Yeah, and that's where it's most worrying. Now we can see here there was a little dip here a little while now. Remember, they stopped contact tracing and everything, even in the preschools. So what happened is there was none of that kind of asymptomatic testing of younger people going on.
So this graph is just 1 to 4 year olds.
This is just the 1 to 4 year olds now. Yeah. So just the preschool age groups where the influences really would only be creche and parents to the largest degree. So very little other interactions here. So when they go up, it either tells you that it's the parents or that it's the creche environment. So if they go up before the parent, you say anything to the parents, it's most likely that environment. But look, nobody can really pinpoint for these graphs anything. It's all a bit if you put all of the bits of evidence together and try and get an overall picture.
Yeah.
So that's for the 1 to 4 year olds. So the levels they have at the moment are bad, but they're roughly this 70 per 100,000 per day. But when we go up to the small age group to the 5 to 14 year olds, so typically your primary school group, it's over double that. So it's a lot more aggressive here. You can see here as well, pretty much since they stopped contact tracing and when the effect of that filtered its way out, with one small break here around midterm, it's been close to a straight line. Now, again, there's so many ups and downs because there's so much this. Remember, we only ever at this stage we're getting about 4%, or that lowish percent of these samples were coming through as positive at one stage. So you've still got all of the other viruses going around. Now in the summer period, that wouldn't be too aggressive, except we saw with RSV and a lot of hospitalizations from that, which at an earlier period that we normally would have. So they'll affect the kind of landscape as well.
So what do you mean by that then is that because people get respiratory symptoms, so they want to present for testing.
Yep.
And whereas in the summer, there was really only one thing that gave you respiratory symptoms. Now there's other things that are giving you respiratory symptoms as well. And so there's a big demand, and that's what's meaning we can't test everybody who needs it as well.
But I mean, everyone who went for symptoms had symptoms. So there's plenty of other things going around. It's just that they weren't doing their aggressive growth the way we've seen RSV here in England. They've seen very fast growth in RSV first, then in rhinoviruses and other viruses that happen every winter where we're normally reacting, but may not have been as much of an issue last year when we were under stricter controls. So last year was much more predictable. This year is a bit of a normal.
In terms of impact that has on COVID testing.
I'll go to that middle, just go through some of the other age groups. So
sure.
The 5-14-year-olds are the ones where there's clear growth despite all of these testing possibilities. The group that we give out about the most, or not we do, but that we hear the government give out about the most, which is the younger group. They're not showing any substantial. Now, also remember, these are the most recently vaccinated group.
Yep.
And we've had really, really good uptake of vaccine. I don't think anybody beforehand could have believed we'd get the vaccination uptakes rates we get, not only in the older people, where you would maybe thought, well, you might get 95%, and we got 99%, but you've got really high uptake even in these younger groups as well. So you're seeing good suppression there. How much of it is real? And that we won't be able to tell from just this data. Around the start of November, our testing system collapsed where demand for testing exceeded supply. So it's hard to read in exactly, but still, even if the case, it means that really bad cases aren't being picked up. That's something good. And like I said, of all of the pictures we're looking at, it's probably the best of the non-boosted groups. So when you get into the parenting group, you're starting to see some trends there, again, going back to when contact tracing ended. The main parents group for primary schools, a very clear group exactly coinciding with that. Again, a fairly heavily vaccinated group. When I hear reports from hospital workers in this age category of where they believe they have picked it up, then most of the time I'm hearing that it's from their kids' schools. Their kids have it first rather than an in-hospital spread. Now that is going to happen the more cases we have, but in the early stages, that was where it happened. And of course, this is the problem with this. Nothing's ever separated. Everything ends up in a loop, a feedback loop, and around and around. And that's why breaking chains, as Gerry will go about, is so important. Again, all the other groups, they all seem like they've hit a plateau, except the over 65s, where we have a booster campaign going on, and it's been really, really effective. It seems to be driving down cases. We've seen driving small reductions in hospitalization in the older groups. Everything's pushing back into the younger, so that's all good. It's not surprising. It's exactly what we've seen in Israel, where they've done all this analysis. And again, for Delta, everything seems to be good. Once you got a recent boost, you got your 3 dose, or not boosts. Israel just says straight out, it's not a boost, it's dose number 3 of a 3, and then next one 4, or whatever it happens to be.
Yeah.
But that's fine. That's what you kind of expect. It's all learning.
All normal.
So this is kind of an attempt, which with horrible graphics, which I only realize now because I threw them together 2 minutes ago, of how to look at, in theory, if you've got a few things going on. So in this corner here, and I think I have markers.
Top left, yeah.
So over in this side here, where we have, this is just the true prevalence. That's what's going on in the community. Nothing to do with measured, just this is what's happening. We've got COVID here. I'm going to put it in as a low number every day, growing at 3% over a period of 7 days. We have this testing infrastructure set up for anybody with symptoms, and it has a capacity of, say, 25,000.
Okay.
But during this month here, there wasn't much symptoms going around, so we didn't need to use up it. So we had these other viruses in the background. They were going steady, or they were reducing. And then it hits their time to shine. And some of them, because we have COVID suppressed with vaccines and also COVID suppressed with other methods. So some of the hygiene and rules we have about masks and on ventilate, all these type of things, they will suppress both COVID and other things, but there are other viruses which it won't suppress as successfully. So these can go closer to their normal growth rates. So some of these will be over a small period of time much faster than COVID. And we saw this in the English data with RSV and rhinovirus in particular, and I think a few other ones that are just popping up, and they take up like maybe 40% of the samples. So it's mainly going to be these kind of ones that we have all of the time giving our sniffles. And then we have another one that again comes along later. So that's fine, that's background, but we're only able to test up to here. So eventually we run into a problem. So we see, again, this is the real one. So what we're looking here is, okay, so then this is what we observe has to happen because we run out of testing capacity. So we get these small little changes. But what we see, even though COVID is going up in reality, what we're trying to observe in a competing field is the opposite. It's going back down. So
that's because, just to put this into other words then, so because it is growing more slowly than the other respiratory viruses, because of all these various suppressions and the vaccine and all these kind of things, it's becoming a smaller proportion of those symptomatic cases that want to present.
And they have the availability of testing to do so. Whereas in Denmark, where they test, so Denmark have a roughly same population. They had one of the days looked at, they had 200,000 antigen tests and 130,000 PCR tests in one day.
Wow, okay. Yeah.
So whereas we have 25 community and around 7 or so, maybe it's increased a little bit, but a certain amount of hospital as well. So the hospital one, there's multiple reasons for the testing there. But in the community one, it's, the reasons we've been told to go testing.
So what you're saying here though is that in this scenario that you're painting, we have COVID going up, other respiratory viruses going up faster, but our testing situation, our testing system is saturated. And because the other ones are growing faster, if you just assume that everybody has equal access to a test, then those COVID numbers will look like they're going down, even though in reality they're going up.
Yeah, again, this is a possibility, but it's also quite likely with the timing of how everything happened. And also that we discussed this with we fed this into an effort a while ago as well. And while they had considered the general background of people missing tests, they didn't consider the background of accelerating of other ones in the
other things. And so it just means, and I suppose the point of bringing this up is it comes back to what do we know and what do we not know. And it's highlighting as well that when you were talking about in certain age groups, things flattening off or not, or the rate of increase maybe slowing down, we don't really, we have reasons to not rely on that too heavily.
Not without testing for some other viruses in the background. So we can kind of say, well, we know what this one should do, and we can measure against that.
And calibrate against
things that we know to be case, even if we have limited testing, or we do what the Danes have. Because the thing with their testing, while I know the HSE want to dismantle it, if they want antivirals to work quickly, they need a very substantial long-term testing ability.
So here you're talking about if we were to have those new antiviral medicines that are being talked about, the idea would be that then you identify cases really quickly, so you give them their medicine really quickly.
Yeah, I mean, you don't want to have to ring up your GP, get the appointment with the GP, then get tested, and then because you don't want. I mean, the GPs are busy enough. You don't want to burden them with every cough and sniffle. So whereas,
I think because I've been through this with surveillance systems for endemic malaria in particular, and like the bottom line is, if you saturate your system, you just don't know what the data means anymore. There are lots of possible interpretations, and the bottom line is, you just don't know.
Yeah.
So
you just don't know, and that's why the ECDC have that 4% as your max positivity rate,
Yeah, and then the positivity rates we're looking at the moment,
What are they at the moment?
they're in the teens, but like I still find them shocking. I just never imagined we'd be looking at. I never imagined I'd be looking at graphs like this for a high virulence pathogen in Ireland. I mean, I'm used to this kind of stuff from my regular work, but that's hollow endemic malaria in tropical Africa. So the fact that these graphs and the questions are the same it means we're in a bad place. Yeah, we're really not in a good place.
Yeah, and so it's other metrics you need to use, like things that need to be looking at will be how much demand is there on the HSC booking site. So how quickly is it booking up every night? So one of the nights I was doing normal work, and it was 2 o'clock, 2 a.m. and I just said, okay, well, I'll just take a peek and see is it as bad as I was thinking. And the slots for City West were gone
Already.
And again, they only, some of them had only been added at 12 that night.
Yeah.
Same, and a lot of so even things like that to kind of get an idea. But the thing is, we just can't trust at this level. You're trying to make up stuff that you just don't know.
And then I'd go further than that, Paul. I'd say, once you're in this situation, there's a whole long list of reasons to get out of it and to not get into it. So the two things that bother me is, first of all, our interpretation of the data is secondary to the fact that it's just a terrible situation to be in. It means we're dealing with thousands of cases a day that are detected, thousands more missed. That means, hundreds of long COVID cases. That means a steady stream of people into ICUs. It means schools under threat. It means all those things. And then what really disturbs me about this one, because this isn't like last January. This didn't just explode on us, right? We cruised into this steadily. Yeah. It went up into the hundreds, it crept up into the thousands, and we never responded. We let this situation happen. I hear, even if our situation genuinely is stabilized, stabilized where?
Yeah.
This is just a it's a very bad situation to be in the first place. And secondly, it leaves us just wide open to get totally whacked by a new variant.
Yeah. And of course, the other issue with this is when we talk about stabilized, the levels we're seeing, if they are true, are still not really at an endemic average level for having reinfections. So this is living with COVID.
So explain to me though that, because so what do you mean then?
So the kind of case numbers we're seeing now, so suppose we see, okay, well, we've got 4,000-ish cases per day. But if you look at some of the older groups, you probably need to bump them up a little bit higher than they currently are. So again, this is why boosters are really important. But the idea of constantly boosting people isn't really living with the virus. It's an attempt to suppress it, which is ideal. But the idea of this kind of that we can just live with it without continuously doing something means that you would get to a stage where, okay, we might expect reinfections on over maybe 16 months, like Iran are suggesting, or less if you've got a new variant. But just suppose with it the same type of flavor, you get to a stage where eventually things will flatten out to a level where you can say, okay, well, this many people should have symptoms, so the levels should be around this many cases per day. We just think we're talking about 4,000 cases per day, and we're worried. But then you have to you multiply it by your 365, and you're still not at the whole population.
So what you're saying,
maybe I can help with this one. There is a concept out there that once something is endemic, it kind of fades away and nobody notices. And that's just not the reality for many pathogens. Yeah. So let's imagine it was just a single variant, then, in a theoretical world, you would reach this flatline equilibrium. And then the question is how, what is the incidence rate at that flatline equilibrium? And that's what Paul's talking about, that it could be like this.
So it's just how, if you have everybody, so you're not doing anything, in your immunity wanes, so you get infected, and it's how quickly you get reinfected. and how many cases per day it is in that cycle. So
Yeah.
if I get infected every 3 months and you get infected every 3 months, it's not on the same day, but on average, everybody is getting infected every 3 months. And that means a certain
so you get into
level.
slow burn endemicity. But even for, perhaps the most stable endemic disease in the world is malaria, but even that goes through seasonal variation, with rain and temperature and all that kind of stuff. And so endemic situations they're never entirely stable, and some of them are extremely volatile. And COVID would probably lean towards that end of the spectrum, because at this stage, it's got quite a bit of antigenic diversification in there. Omicron is kind of a joker card on that front. And so probably an expectation of living with the virus, an endemic scenario, would be lots of fluctuation around that theoretical average, based on a couple of things. First of all, seasonal environmental variation, but also fading immunity. And then, so a lot of things, they go through cycles as immunity fades, and then there's an outbreak, and then immunity is reaccumulated. But then the real joker in the pack is evolution. And it's, and that's a standard thing for coronaviruses. The more extreme versions would be things like dengue, where, you've just got kind of fairly unpredictable, sporadic outbreaks of different variants that are so different. They're immunologic, they induce totally different immunological responses. So like our living with virus future, I mean, none of us really know exactly what it would look like, but at least on an intermittent basis, it would look like where we are today.
But even so, which is pretty crap, because I mean, we've seen so many hospital services being cancelled. The one that sticks in my mind so much, and I find it's so distressing, is the transplant operation we heard that was cancelled because there wasn't an ICU space. That's just devastating. And there's other things as well. But, I think if I'm understanding you correctly as well, our current daily case rate is not stopping at, if it even is stopping at 3,000-4,000. It's not hitting there because that's the max level that's going to happen. It's there because we're doing so many other things to suppress it. And if we did just say, okay, if somebody foolishly, yet full of confidence, as happens, said, we're fine, it's all over, we can do everything as normal now, the cases shoot up to something much higher, and that would be our endemic level, which would see nothing happening in the hospital except COVID care. And we would not have a health service anymore.
Or just to give anyway. Just to give, because I know for a lot of people that's a very hypothetical scenario, but like these things do happen across large parts of the world. So the one I'm familiar with is, and this still happens in a lot of the kind of wetter, hotter parts of Africa, is that at least on a seasonal basis, 50% of your patients are malaria, and then the outpatient facility is full, and you've got patients spilled out onto the street. People with drips in their arms, all the way out onto the street, and that happens every year. And so you get a single pathogen that just dominates the health system, distracts from everything else, and keeps the health system pretty overwhelmed for at least, say, 3-4 months a year. But
I'm sure people are going to think or hope that our health system is stronger than that, and it won't end up like that. And I think that's what people, when you tell these stories, most people who are listening in Ireland won't know Tanzania except from a small number of snapshot images, and they will imagine that we won't end up there because we've got better hospitals or something like that. I'm not saying it's a well-informed opinion, but that people probably think that won't happen here.
Well, the only difference, is here we've got trolleys.
Okay. But I mean, I suppose we are already cancelling hospital services.
Yeah. So I guess my key message is, like, this isn't all theory. It's not all maths. These are lived realities for many people around the world. Thank God we haven't seen that in Ireland for a couple of generations. But it's living with the virus. if people want to do that, then we might need to accept a very different reality to the one we're used to.
And I don't think anybody wants that, right? Nobody wants that.
That
I don't think people understand that, or they don't see any alternative, because no alternative, like if you listen to the governments and, you know, around Europe, they're mostly the same as each other, right? There's small variations, but they're not big variations around Europe.
Well, I'd love to see, I mean, if we have so much faith in our epidemiological modeling team at NEFIT, I'd like to see a simulation that goes out to, say, 5 years from now, inclusive of evolutionary processes.
Well, forget evolution. They didn't even include reinfection in the basic.
Yeah. So
they had presumed, like, so when we were having that conversation earlier about, oh, you get infected and you get infected, is it 3 months later or is it 16 months later, or what is it? The models that NEFIT were working off were presuming that after infection or vaccination, you never get anything ever again.
Yep. And even when they put in the waning for the vaccines, even when that was added in, which again should have, even then they didn't put in waning for acquired immunity. Okay.
So they actually,
wow.
And from what I hear people say the opposite, that acquired immunity is not as robust as
exactly
the vaccination-based immunity.
Yeah, I mean, in terms of the vaccines, what you're looking at your mRNAs, acquired immunity, AstraZeneca, Janssen & Janssen, and that will be roughly the order for a while.
Yeah. So there's lots of theoretical and non-theoretical reasons that all converge to say, you know, that future living with the virus future that we've been sold does not look like normality.
Yeah, and I suppose one thing we've been sold in the last few weeks is that Omicron is mild, which is not really what we're seeing in South Africa. Now, you get the reports because COVID is on average mild, as is polio, as is malaria, as is, you know, pretty much everything that doesn't kill 30% of the population. But when you look at now this is from the Financial Times, John Byrne Murdoch, he does these great graphics, and I didn't have time to do it myself, so I just nicked it him, but credited there. So we can see here the cases going up faster for Omicron than at any point. Now, how fast is this going up? Is at least as fast, possibly faster than Alpha grew in Ireland, underneath all the wild type last year. So actually, we had the worst growth of anything other than Wuhan, but of Alpha. But we stopped it late, but still, at least we stopped it before it got too far. But it's not, and then the sort of thing is, oh well, it's great, it's more transmissible, so therefore it's milder. That kind of again, but their hospitalization is also going up faster than any other wave so far, and this is something that has to be updated, like, because your hospitalization here, the data actually lags. So this is based on weekly. So but they records in, so it keeps increasing as they get more data in. Now this is in South Africa, in the main province where you've got the capital city and other things. Their population in that area that are over 65 is about 4% of their entire population. In Ireland, it's about 19%. So we are heavily betting that those boosters, before we're really sure, are going to work by keeping things fully open the way we are right now. So that's a very, very high risk game, because we don't know, and I don't really like the part of taking part of it in an experiment that I don't really consent to. I think informed consent is important for any type of an experiment. And this is basically a large scale trial of whether a vaccine that was designed for something else that did work very well against Delta when boosted, if it will work against something that's a lot different than Delta. We've even seen reinfection wise, a lot of Delta people who got infected with Delta only a very short period while ago have been infected with this Omicron. They don't have to worry in South Africa about co-infection, because they went through their Delta wave nearly completely. With, like, they estimate over 75% of their population have been infected prior to this. There's another good portion as well who've been vaccinated, so they have really high levels of immunity to previous variants.
And then the thing with, what you were saying, people were very quick to, some people were very quick to believe that it could be mild, but at the same time as they were expressing caution about, does it spread quickly? So they were emphasizing, we don't have much data to know how quickly it spreads or anything about immune evasion, but it looks like it's mild. They weren't exercising the same caution in interpretation. They only exercised that caution for the negative news, and were less, we're more credulous for any positive news. And whereas we would all love, anybody will be delighted if it's milder, but like you said, Paul, it was a small number of individuals who happened to have be part of the population where we don't expect things to go as bad on average because they were younger on average.
Yep. And
what are you showing us here?
This is Gerry now.
Oh, Gerry, go and show me.
Yeah, but this is why I'm nice to people like Paul, and I try to be nice to other people who are smarter than me overseas, and we're very lucky that South African science is really doing what it can do, and we're learning, we're getting more information out of this, and just as the Indian scientists and the Brazilian scientists, served us. Served everybody on the planet by delivering top quality scientists. This is an analysis of data coming out of South Africa from Trevor Bedford in Seattle, and he's got a long thread. But I really liked. First of all, it all makes sense, but then I just really like his way of summarizing what we know so far, and basically, we can worry about virulence later, because actually that's probably not the biggest concern. The level of virulence of the pathogen per se is not the biggest concern, because if anything, higher virulence makes things easier to contain, because people take it seriously, and because it's easier to spot cases because they become more overtly symptomatic. So the two parameters that really matter and that will determine what Omicron does to change our future, it really depends on its ability to evade immunity to existing variants and its intrinsic transmissibility, which we express here as its intrinsic basic reproduction number. Now, I think he's got it absolutely bang on with this diagram, where he puts the existing variants and where he expects Omicron to fit on this graph. Now, what we're
looking at here.
What we're looking at on the y-axis there, like the vertical axis, we're looking at, basically dilution of immunological responses. So in other words, that's an indicator of just, how well antibodies to obtained against COVID in the past will work against something. Okay. And when you see
higher value there is more immune escape, essentially.
Yeah, exactly. So 30x, when you see 30x there, it means that you'd need a 30-fold higher concentration of antibodies to stop it. And that doesn't translate into vaccine efficacy, but when you compare that with the level of immune escape exhibited by alpha, gamma, beta, and mu, it gives you some idea that Omicron is probably a whole new step change.
Just how high that axis goes when you consider, the highest one there is mu, and it's about 10.
Yeah.
And that axis is going right up to 35.
So we're probably dealing with something that that is immune evasive on a level that we haven't seen before from other variants, even though the process by which it's emerged looks really similar to gamma and to delta. But now we're not sure about transmissibility. If it is more transmissible than delta, it's probably not much more. Now, and what's probably driving that relative change is probably a little bit of it's either a little bit of increased transmissibility or lower transmissibility, but then this ability to burst through pre-existing immunity that that so the bad, there's good news and bad news. The bad news is that it's probably more immune evasive than anything we've seen before. The good news is that what we're seeing is probably mostly a result of that and may not necessarily reflect greater transmissibility than Delta per se. And that's good news because
the idea is it's spreading in South Africa because the advantages has in South Africa is that people there have immunity to the prior versions. So those prior versions are at a disadvantage. So Delta and whatever are at a disadvantage because people are more immune to them. And the advantage Omicron has is exactly immune evasion rather than an inherent intrinsic better
probably
ability to, so yes, again.
Most probably, but
the favored hypothesis at the moment as we are gathering data and still understanding
what it looks most like. But as you can see, most of that graph is empty space, and that's a very large oval drawn by somebody who really knows what they're doing. And that's a very large dartboard. And we don't know where the dart's going to land. Now, if we ended up with something closer to the top right-hand side of that, then probably
top left, you mean?
No, top right-hand side.
Okay, so there's no oval there. Yeah,
there's no oval there.
But even disaster stations.
Exactly. So, if the dart landed somewhere up there or even anywhere on the edge of that oval, the top right-hand edge of that oval, it is possible that our goose is cooked. And then you've got something that, if you've got something that's as transmissible as Delta and our vaccines don't work, then
we're back to square -5. Because we're not even back to the beginning, because the beginning it wasn't as transmissible. So if the immune evasion, okay, so this is also as immunologists are keen to point out, there's more to the immune system than just the antibodies, and thankfully for that. But if we have something that evades previous immune response, so essentially everybody is back to not quite totally unprotected, but there's much less protection and it's really infectious. If both of those things happen together, everybody's getting it.
Exactly. So if we ended up in that scenario, the bottom line is Delta is about at the absolute limit of what can be contained with non-pharmaceutical intervention. So like the good news is, as long as it stays below that transmissibility threshold for Delta, even if our vaccines fail, we do have alternatives. Now, they're harsh alternatives, but they exist. If we, and that would be a tough way to go back to only non-pharmaceutical interventions. Now, I'm kind of still keeping my fingers crossed and hoping that we get something that is not as transmissible as Delta, but it's unlikely to be much less. It may be vaccine evasive, but not entirely. And then we're still in the part of this graph where containment is possible and there's ways out of this. So, and fingers crossed. But what I really want to make clear to people is we don't know where the dart's going to land. Now, if we get lucky and the dart lands on the part of the dartboard where we still have options, then let's just thank God for our lucky, the lucky break that Mother Nature has given us. And, let's not push our luck any further, because the thing that, so like there's a good chance with Omicron that actually this is something that we can manage. But it's also possible that is not the case. And then I don't have answers, and I'm not sure anybody else does.
So if it can't be managed, then
let's not even go there. Let's not even go there, because then, I don't think any of us have answers.
Well, I think maybe in richer countries we might have a chance of doing some things.
I'm even talking about richer countries, So let's hope for the best. But the key thing for me is every time we get lucky or we make progress, we relax, take it easy, and say, okay, grand, we're going to be okay. And let's reopen the pubs. Let's, you know, we keep stretching our luck until it breaks. And
I feel like, you know, you're in a space that's flooding and you see the water going up, and eventually when it hits you around the waist, you're going, oh my God, and you start bailing out. And then it starts going down again and it's only to your knees and you're so delighted that you've got it going down. You're like, oh, thank goodness. And you're happy again. And you only pay attention when it's up to your armpits next time.
Yeah. So my message about Omicron is, like, this is a bullet. If it zings past our ear, you know, let's not celebrate by jumping out of the trench and dancing up and down, because there's two things that concern me. One is our general attitude to we lack objectivity. We tend to lean on the optimistic side every time we get a lucky break. And secondly, it's the evolutionary history of Omicron is really troubling, and it's not entirely it's not something that we never conceived. Its evolutionary roots look really disturbing. It's really a curveball. This is where the virus is really pulled off.
In terms of how many changes it has.
Yeah, and there are ways to explain that, but this is a step change in terms of the virus's genomic creativity, let's call it that. Yeah. So, you know, there's no reason to expect that this is the last variant, or that
we're having a new variant of concern every 6 months now.
Yeah. So
and you know, people are each time going, well, this will be the last one. And it's like, how are you so sure?
Yeah.
And you know, we have not run out of, you know, space for genomes to change here. You know, have you not noticed how much? Like, if you want to talk about genetic diversity, it's you know, there's a huge amount of possible genetic diversity. It's anyway.
And we're dealing here with a virus that has a pretty good track record on genomic diversification. Yeah. And the thing that worries me about Omicron is that there's signs there of having evolved through a pretty stable animal reservoir. And so that's, whether it's that or whether it's some chronically infected individual living on a hill, you know, with a farm of their own and feeding themselves for a year.
Or what about a part of the world where we're not really doing surveillance? That's a lot. There's a lot of the world where there isn't surveillance happening.
No, it could not. We would have seen it before. Yeah. This is something that's evolved in isolation. Now, it's not just Omicron, it's the process that gave rise to Omicron. So we have to pay attention to that. And as long as we leave it to throw curveballs at it, that's exactly what it's going to do. So I you know, that has implications for what a future endemic scenario would look like. So that's a future we should reject.
Yeah, maybe could you just close the slide, because I think Paul has something he wants to share as well. But in your scenario, Gerry, the bullet whizzing past our ear as opposed to hitting us it whizzes past our ear if we're lucky enough that Omicron is not hugely infectious and also not really immune evasive. Then we've got lucky in that sense. We weren't hit.
Well, we could cope with one or the other, but not both.
So we'll see. We'll know soon what it is.
If we get a little bit of one and a lot of the other, it'll be a struggle, but we'll probably find ways to cope. If it's a lot of both, then I don't know.
Coping. And people will be wishing they did what? Because there's the things we should have done, the things we could do now, and the things we will do, or we hope we'll do if it only whizzes past our ear. Oh, here it is.
So I suppose this is the thing on how important it is to act quickly and how much extra options it gives you. So in this situation, we spend the same amount of time in restrictions, 3 weeks.
Three scenarios in these 3 colored lines.
3 scenarios, 3 colored lines. Each of them, we spend the same amount of time with strong enough restrictions to suppress it, and strong enough and relaxed enough so that it spreads. If you can act early and say, okay, week 1, we're going to do something even before we know it's for sure, that we don't wait to see people dying before we take action, then you can say, okay, well, we might just take a time off. Then we can put those restrictions back in, and you can kind of have a cycle of restrictions to allow us to maintain some social interactions at some degree of level, while realizing that yes, people will still die from this. We are going to put some people in hospital. bad things will happen to some people. But if we do it the other way and say, well, let's wait until we see that it's bad enough, we end up with the yellow curve here, where you just end up with so many people getting hit that you still have to shut down everything anyway. So you can't just say it's past you, because your hospital system is overrun. So you can't do any of the other things like DIY or construction, because there's no hospital backup system for you. Even going for a drive becomes,
if you have a crash, there's no hospital bed for
there's
you.
no hospital, anything, like all of our, if you have people like, so if you have a long period of time where you're going to have no cancer treatments, no diagnosis, as opposed to saying, okay, let's see, can we manage this in some creative way until people cop on internationally that we need to manage this internationally.
So tell me what we're modeling here. So what kind of infection rates are modeled?
So I honestly can't remember the infection rates or anything. They're all the same properties of the virus. What we've done is we've put in the same impacts early in a few different ways. So one of them is week on, week off. So so you kind of have a week of really strong restrictions, enough to hold this down.
A week of stay at home.
Week of stay at home. Well, we know what doesn't really overly spread. So certain outdoor activities where there's space. Retail, seemingly in Australia, where people didn't have too much, and the customer end of the thing didn't observe too much transmission in that setting. So there might be room for like masks and including space and all these type of things. But things like offices, indoor dining, anything where you have an exposed mouth, you're getting issues.
But I think that's maybe we're getting lost in the weeds there a little bit. I mean, your basic messages, because this is a hypothetical scenario. Yeah. It's not like we'd all just go for pints every second week. But the key point here is that allowing continued growth over extended periods is the kiss of death.
Yeah.
I mean, it's the thing. We need to break it. And even for now, if we want to see what Omicron's like, let's not be the people who figure out what it looks like.
The hard way. That's the thing. I mean, this is the frustration, isn't it? Because it's exactly the same conversation we had about Delta. Because people were saying maybe Delta isn't that bad. How will we know? We'll know when we're swamped with it. That's how we'll know. We'll know when we're overrun with it. Or we act as if it probably is like that or might be like that and avoid it. And we're having the same discussion with Omicron, essentially.
And we'll probably have the same discussion again in 6 months' time.
What's the next letter we're going to be using in 6 months?
I think it's someone did joke about it being Thanos, TH, which is the Greek god of death, isn't it?
All right. And why is it not? Is Omicron anyway? I don't know. Why not Theta?
I think the key point here is let's not go there.
Yeah.
Let's not go there. In the real world, they're not simulations. They're not.
There's no rewind.
Yeah. So what do you say to people who think, so plenty of people think that, it can't get worse than it currently is. So we're living like this. It's pretty awful, but we can't sustain this. We have to get back to some kind of normal life. So they think I've had enough. I can't deal with this anymore. We have to get on with things. That's what a lot of people are feeling. So how do you answer that? And these are not people who are callous or uncaring. They just think they
need to read the fine print before they sign on the dotted line.
But there's nobody giving them the fine print, so we need to give them the fine print.
And that's one issue I think we should talk about. None of this is a secret. It's all available through the best journals in the world. A lot of the science for understanding these things, it's decades old. And so where are our science? First of all, where are our science journalists? Secondly, when are our editors and producers going to allow this kind of stuff to go out? And then when are we going to actually start listening? Like one of the few notable exceptions to the poor standard of science journals so far has been Mark Coughlin, and particularly the way he covered the issue of herd immunity. And,
I think
told us all very plainly that, if you make, reasonable assumptions and you apply standard well-established models, you would expect herd immunity thresholds to be, 90% or very close to it. And that includes all kids. And nobody paid attention to that. We all sleptwalked into reopening the schools. That was all spelled out for us. And so the big challenge for us as a society is to get past wishful thinking, to get past a bias towards feel-good interpretations, and to deal with this on an objective technical basis.
So Gerry, so what would you do? What would you do now if you were handed the reins?
Well, the fact that schools are under threat and yet we have nightclubs open is, that's the first place I'd start. Education is a human right. Restaurant meals, pints, a little bit of Saturday night fever is not. There are things we need. We have vaccines on our side this time. And so far, at least, fingers crossed about Omicron, that'll hold up. But in the situation we're in, we'll really start with the vaccines, will really start doing bigger things once we have young children vaccinated. But that's going to take time. So in the meantime,
you would close hospitality until that vaccination.
Absolutely, and support those industries. Really support those. So anything we don't need, anything that's indoors. I'm sorry for those folks who exercise in gyms, and I'm sorry for gym owners, but I'd be closing down those pantos that children are discouraged from attending are kind of pointless anyway.
But this, I think, is a bit of what did I call it? Like speaking out of the side of your mouth or something. They're not closing things, but they're closing them.
Yeah. So the good news, there's good news and bad news about epidemics having tipping points. The bad news is once they tip the wrong way, you get in serious trouble fast. The good news is once you tip them the right way, we could actually start making progress really fast. And we should, a lot of the tension has drifted away from places like Australia and Japan recently, but people should take a close look at that. Japan has gone from 20,000 cases a day back in, I think it was August.
Well, the Olympics had a big crisis, yeah.
80 cases a day, and they're, and that's why they were so quick to impose travel restrictions to protect themselves against Omicron, because they've really established a strong position for themselves where they're, if they do have an Omicron outbreak, they'll be able to see it, and they'll be able to throw the kitchen sink at it.
So you would have. So I'm trying to, because I think we're running out of time. So we'd have like temporary, like you close hospitality until.
No, the key part here is whatever we do, we stick with it until the job is done.
But when, so the long-term plan, the job is done when?
Summer. Let's get out of this by summer, get ourselves into a defensible position. So like New Zealand at the moment is back down to, they've got Delta on the retreat. They're back down to 127 odd cases a day, but every single one of those is traceable to a source. So they've got a fighting chance. They've got a good fighting chance. We need to do that anyway, because, we've got about, 3.5 weeks till Christmas. If we let this thing start cooking up, in the run up to Christmas, Delta alone will cause a pretty traumatic Christmas. But that also just leaves us wide open to get whacked badly by Omicron. And these things, can take an awfully long time to recover that kind of lost ground. And sometimes you just can't. Sometimes things go too far past their tipping points, and it's really difficult to regain that lost ground, if at all. So yeah, no, we need a response that is technically informed and serious and has a short, medium, and long-term plan with a defined exit point, rather than limping along from one week to the next, trying to come up with some fictitious technical rationale for a whole bunch of mistakes that have been made so far. I've said it before. Change your mind, change your plan, but don't waste our time with political and corporate spin trying to convince us that this all makes sense, because it doesn't. And most of it's just window dressing.
Yeah.
You know, rapid tests to stop a new variant from coming in through air travel. I mean, that's, as Paul would say, that's full Harry Potter magical thing.
Rapid tests that aren't even being used rapidly. I mean, the only advantage of the antigen, as far as I can tell, is how quickly you can use it. And then they're telling them to do it 70 whatever hours in advance, and as if the result still applies. And
you use it
I mean,
before you leave
it's
the
like,
country.
at least if they were doing it at the gates, you might say, it's an extra piece of.
You might stop what, 5% of the incoming?
You might, yeah, what I mean. But like, if you had PCR tests 72 hours or whatever the number of hours they allowed is, and antigen tests at the gate and other things, like if you used it in a suite.
So it's not a technically informed response.
No,
it's being seen
improvised.
to do something while actually not doing anything.
There'll also be this attitude of, once it's here, we may as well let the flights come in. That will come back up again. The real problem with flights over any other mode of transport is it's a tin box where one person comes on it, and we've seen it multiple times, even in Ireland when we had low enough numbers that we were able to do it, and 10 come off.
Yeah.
With it. So it's
a little incubator.
It's like a magnifying glass that two countries interacting could be doing okay with it, and literally having that transport link where you've got magnification in between could be enough to. And
then queues in the airport.
Compared to varies, yeah, and everything around it.
Queues in the airport.
So this is awfully bad news for a lot of people. People are just exhausted with this, and I think I think my feeling is that there's a huge number of people who just want to hope for the best rather than face up to this, because I think that's the feeling I get. It just.
Well, I think the key conceptual thing for a lot of non-specialists that's very, very important is that, if you take it on the chin, that's not the end of it. It's just, it becomes a cycle. And so, this vision of we get through, a final wave and then it'll all be okay. No, it won't be. It just becomes the start of an endemic cycle that will be won't be entirely stable. It's unlikely to be entirely stable. It's probably more going to be, it's unlikely to be as volatile as dengue or malaria, but it'll probably be, it'd probably be somewhere in the middle of the spectrum where, we probably get whacked somewhere between every year and every 3 years. Mm-hmm. And nobody really knows for sure, but the chances of it all just, everything going back to normal is negligible in my view.
That's depressing.
Yeah, but that's what people have been told. This is the image, and none of those simulations go past. They don't go into the long term. Then they don't go into the long term, and those and then the people who are given this advice have no prior experience of real high virulence endemic pathogens. They've never lived through it. So I just think that for me, when I listen to the way that story is sold, and then I compare that to my own experience of these things, it's like two parallel universes. So just anybody out there in the public who's curious, interested in buying this car, open the hood and start asking awkward questions. And then start asking yourself, well, haven't we been promised this 3 times before? Isn't this our 3rd time trying to ram the iceberg and hope to sink it? How many more times are we supposed to turn around and kind of bounce off this iceberg in the hope that it's going to magically dissolve into the North Atlantic? It's time to ask those questions.
And there's the appeal of short-term, quick solutions. I think we should probably wrap up here, actually, because I think we've covered everything, and I think we've run out of time as well. So I think hopefully that's helpful to help people understand, what the current situation is, what the concerns are for the future of this with Omicron or without. I think we were already in a bad situation, but it's not good news, unfortunately, except in the sense that there are things that can be done. There are routes available. It's not a quick and one solution, one size fits all. It's not going to be just one single thing that's going to fix it all quickly. It's a big job to fix it, and I think that's what needs to be faced up to now. Okay, thanks, Paul. Thanks, Gerry.
Thank you, Aoife. Thank you very much.